What we're going to talk about is just who is appropriate for treatment, what do you use for treatment, and for how long do you treat somebody? And this is always a hot topic of debate. All right, so I have no disclosures relevant to this talk, and I will not be discussing any off-label or investigational agents. So let me just start with a quick case to think about as we go through the talk. This is a 45-year-old man who presents for follow-up with hepatitis B. He feels well, he has no complaints. He's been on treatment for over 8 years now for E antibody positive chronic hepatitis B with entecavir. He is coming today because he wants to stop treatment if possible, as it costs him $2,000 a year, and he has to start paying for college for his children. So he's looking to start saving some money. His labs show his ALT is normal, his Hep B is undetectable, he's surface antibody negative, he has no fibrosis predicted by FibroScan, and he has an ultrasound that has no cancer or cirrhosis present. So the question to think about as we go through the talk is, can this patient stop his medication or not? So as part of the lecture, I'll quickly discuss a refresher on terminology that we'll use in these patients. We'll go over who should be treated based on current guidelines, talk about the goals of treatment, the choices for treatment, and whether or not treatment can ever be stopped. So the terminology that we use has changed a bit in the past few years, but since 2018 in the United States, the preferred terminology is here. We talk about immune tolerant chronic hepatitis B who are E antigen positive patients with normal liver tests but a high viral load and no significant damage. We have immune active chronic hepatitis B patients. These are the group of patients that we're going to focus on today, who are generally the patients that we're treating. So these patients have both liver inflammation and high viral loads, and they could be either E antigen positive or negative, and they often will have liver inflammation or fibrosis associated with that. And then there's the last group are inactive chronic hepatitis B patients. These are patients who are E antibody positive with normal liver tests and low viral loads. In Europe, they use slightly different terminology, so either chronic infection versus chronic hepatitis, which honestly is a little less confusing, but in the US, this is what we use, and we're going to focus on the immune active chronic hepatitis B patients, who are the patients that we treat. So what do you need to know in order to treat somebody? Basically, you need to know about 4 things. You want to know their E antigen status, what their liver enzymes, particularly the ALT, are doing, what their hepatitis B viral load or DNA quantification is, and whether or not they have cirrhosis. There are a few other helpful things that you can look at, including whether or not they have any fibrosis. Do they have co-infection with hepatitis C, D, or HIV? Do they have chronic kidney disease? Is there a strong family history of liver cancer or cirrhosis? Are they somebody that's either had a transplant or may need a transplant of some solid organ in the near future? And also, do they have any bone density issues, particularly osteopenia or osteoporosis? So if we go down a quick algorithm, the AASLD has recommended that these patients who have immune active hepatitis B, again, are the ones that we're going to treat. So for an E antigen positive patient who has high liver tests and a high DNA, those patients should be treated. For patients that have a high viral load but normal liver tests, those patients do not require treatment. And for patients that have in between those numbers, they usually just get monitored. So again, high liver tests, high viral load, treat them. For E antigen negative patients, same algorithm here, high liver tests, high viral load, you treat them. Just note that the number of the virus is different for E antigen negative patients. You're allowed to have less virus when you're E antigen negative. So your cutoff here is 2,000 international units per ml instead of 20,000 for the E antigen positive patients. But same concept here, high liver tests, high viral load, treat them. So other things that you want to think about here when you're treating patients, if they have co-infections, either with HIV, HDV, or HCV, generally we err on the side of treating these patients for hepatitis B as well, regardless of their liver tests or their viral load. If they're cirrhotic, they get treated. If they're immunosuppressed, say they're getting chemotherapy for cancer, they get treated. And those patients generally remain on treatment indefinitely as long as that condition continues to exist. Now, in patients who have a strong family history of liver cancer, these are also patients where treatment should be considered despite the lab results. This is an individualized question, and as we'll see later, sometimes this treatment is going to be indefinite, but it does give patients a modicum of self-worth to know they're doing everything they can to treat and prevent cancer. And so what is a strong family history? Usually I would say 2 family members, first degree, maybe a first degree and a second degree. One family member may not be enough, but it's something to talk about. You should stage all of these patients, as any fibrosis usually should warrant treatment consideration if it's felt to be from hepatitis B, as one of the goals of treatment, as you'll see, is to reverse the liver damage. Just a couple other pearls for management. These patients should all be screened for hepatitis A immunity and vaccinated if they're not immune. They should be avoiding alcohol, or at least excessive alcohol, and household members should be vaccinated if they're not already immune to hepatitis B. So I alluded to some of the goals of treatment, but generally there are some big picture goals. They pretty much are designed to prevent complications of hepatitis B, which might include cirrhosis, liver failure, liver cancer, or hepatitis B related death. There are some extrahepatic manifestations associated with hepatitis B, including kidney disease or cryoglobulinemia that can be present, and it would also be helpful to prevent those. Now, in reality, it's very hard to measure these big picture goals because they take a very long time to develop. So there have been surrogate markers of treatment success that we'll look at on a day-to-day basis or week-to-week basis. And these include normalization of liver tests, particularly ALT, virologic suppression of the hepatitis B viral load. In patients who are E antigen positive, losing that E antigen and developing an E antibody would be a goal of treatment. In patients who are E antigen negative, the goal of treatment is to lose surface antigen and convert to surface antibody. Now, this is unfortunately not super common of an occurrence, but this would be an ultimate goal of treatment. And it's this sort of S antigen loss that's really our ability to give a patient a functional cure. So that's going to be our target when we discuss some of the treatment cessation guidelines. Now, when it comes to other treatment success markers, we do want to see improvement in liver histology. Now, we're not usually biopsying these patients, but we can see improvement in, say, inflammation based on blood work, and we can see improvement in fibrosis based on elastography monitoring. So now you've decided you have an immune active patient who's got a high viral load and high liver tests, and you want to offer them treatment. Which treatment should you use? So the treatments that are recommended by the guidelines are treatments that have a high barrier to resistance. These include entecavir at 0.5 or 1 milligram daily, which is a nucleoside analog, tenofovir disoproxil fumarate, 300 milligrams, a nucleotide analog, or tenofovir alafenamide at 25 milligrams, also a nucleotide analog. The 2 types of tenofovir have the same active drug with a different carrier molecule, thus the different weights of the drugs. Entecavir and tenofovir disoproxil fumarate are both available generically, and tenofovir alafenamide is still available as brand. There are a couple other approved medications, but they're not currently recommended, including lamivudine and adefovir, as well as peginterferon, which is alpha-2A, sorry. Telbivudine was also a historically approved drug, but was discontinued in the US in 2016. And so generally speaking, patients are going to be on one of these 3 medications up top. There are going to be patients that might be on lamivudine or adefovir based on insurance needs. And you could potentially consider one of these drugs, which are lower cost in low risk patients where the cost of the treatment is more important than the small risk of resistance or less efficacy. The other thing to consider when you're picking the drug is that it's not always our choice. So sometimes insurance preferences can play an important role here in the decision process. This is also the case with hepatitis C drugs. So I try to manage expectations when I'm offering treatment by, telling patients, we have a few good options for treatment. Most times it's 1 pill a day, but it is important to say that this treatment may be for the rest of your life, that I'm hopeful at some point we'll have some medical breakthroughs in your lifetime that will offer a chance to not need medication forever. But at this point, a lot of these patients, particularly for the E antigen negative patients, the treatment is indefinite unless they develop surface antigen loss. For patients who have chronic kidney disease or bone density loss, generally we avoid tenofovir disoproxil fumarate, as there's some evidence that it can exacerbate chronic kidney disease or bone density loss. And so in those patients, entecavir or tenofovir alafenamide would be preferred. If the patient had taken lamivudine in the past, chances are if they're not still on it, they have resistance and they should use a tenofovir-based regimen. And for patients who are on entecavir or tenofovir disoproxil fumarate, they are renally dosed, so it's important to monitor their GFR. Tenofovir alafenamide is not renally dosed, so it's safe across all spectrums of kidney disease. Just a note about efficacy of treatment. I'm going to call your attention to these red circles here, which will show you that with all of these treatments, there's a high level of suppression of virus, but I will call your attention it's not instant. So for patients who have e antigen positive state, have a higher viral load, it takes them longer to suppress their virus. And even by the end of a year, only about 2/3 to 70% of patients are fully suppressed on treatment. So it can take several years sometimes in these patients to get complete virologic suppression. The ALT does normalize faster, and by the end of the year, over 90% have normal liver enzyme tests. But again, the viral load may drag. So if you still see detectable virus, it doesn't mean it's not working, but you do want to see it consistently decreasing. For the e antigen negative patients, the virus does come down a little quicker because these patients have lower amounts of virus to start. I will also call your attention just briefly to the bottom line here, where for surface antigen loss is very uncommon here. And so for most of the time, you're seeing low rates of surface antigen loss, somewhere in the range of 5% at 5 years or more of treatment. So when you're on treatment for hepatitis B, we do want to monitor to make sure it's working. I mentioned that some of these medications require renal dose adjustments. So getting a complete metabolic panel, not just liver tests, is helpful to make sure you're on the right dose, as well as a Hep B DNA to make sure that the viral load is coming down. Generally every 3 to 6 months. I usually do it every 3 months if I'm starting medication. If they're stable for a while, I might go to every 6 months. These patients should also be screened for liver cancer as per current guidelines. So if they're over 40 in a man or over 50 in a woman, generally those patients are getting screened every 6 months with at least an ultrasound plus or minus alpha fetoprotein testing. If you're monitoring a patient on treatment and you notice their liver tests are going up or their DNA is rising despite treatment, you want to first assess for adherence. The most common cause is they're not taking it properly. You want to potentially check for hepatitis D superinfection, which can affect patients with hepatitis B, screen for risk factors, or just check for HIV or hepatitis C. And then also ask about any other new medications or supplements that may cause liver injury that they're taking. So the big question that patients will ask is, when can I stop? As I alluded to in our case presentation. So I think it's important when you're considering stopping treatment to recognize that we do not have a currently available cure for hepatitis B. So the functional cure, or the sort of best target of treatment, is loss of surface antigen with conversion to surface antibody. But as I showed you briefly, it's very uncommonly achieved. The other confusing thing about stopping treatment is there are different endpoints for patients who are e antigen positive or e antigen negative, and I'll show you that in a second. When you're weighing the risks and benefits of stopping treatment, if you stop them too soon, you run the risk of having this patient flare their hepatitis and develop a reactivation hepatitis, which can be pretty severe sometimes. You run the risk of drug resistance by taking the pressure off the virus. And you also increase the risk of clinical outcomes like liver cancer or liver decompensation. Now, on the flip side, overtreating patients wastes money. These are not inexpensive drugs. And there can be potential side effects, as I mentioned, like kidney disease or bone density loss for some of these patients. And so they may be clinically significant. And I would say the biggest reason that patients ask to come off of treatment is cost. Even though they may be covered by insurance, a lot of patients have high deductible plans or copays that are difficult for them to support continuously. Now, a note about resistance. Fortunately, this is not a huge problem with these medications. And it was an issue with lamivudine and entecavir, a little bit with telbivudine when that was still out. This is a table from the European guidelines about treating hepatitis B. But as you'll see here, for entecavir and tenofovir-based therapies, there's almost no resistance, even up to 8 years out from treatment. So, I think you don't have to be too afraid that if you have an adherent patient who you decide to stop therapy on, that they're going to develop resistance. You can usually restart the same medication. But for non-adherent patients, it is certainly an issue, as we see with any viruses. When it comes to stopping treatment, there is some guidance from the different societies around the world. And I'll show you this table here. Is a little hard to read, but you'll have the slides later to look at. And just to highlight, APOSTLE is the Asian Pacific Association for the Study of Liver Disease, the American Association here, and the European Association on the bottom. And I want to focus on the e antigen negative patients for a second, which is the right side of this table. As you can see, for all of these, the goal of treatment is going to be surface antigen clearance. In the American guidelines, basically, that's the only way you're going to stop therapy in these patients. And if they're cirrhotic, and have e antigen negative state, you basically just are recommended to keep them on drug forever. Now, in the European and Asian guidelines, though, they do lend for the potential to stop treatment in some patients who are not cirrhotic if they have suppressed virus for several years, 2 years in the Asian guidance and 3 years in the European guidance, and you have documentation of undetectable DNA a few times over that period of time, you may consider stopping treatment in these patients. And I think a question that most Americans have asked is, why would they recommend that? And it really has to do with the idea of provoking surface antigen loss. Again, because right now that's our only functional cure potential. Now, for patients who have e antigen positive state, the goal of treatment initially is seroconversion of e antigen to e antibody. So if you do that and the patient loses their e antigen, develops an e antibody, and has undetectable virus with normal liver tests for at least a year, those are patients where you could consider coming off of treatment and monitoring them. Now, they may move over to the next category of e antigen negative patients who need to be treated with time. So they definitely should be monitored at least every 3 to 6 months, and often a little sooner when they're coming off of treatment just to pick up a flare. So I'm just going to raise the question of whether we should be thinking more about stopping treatment to clear surface antigen. As again, this is our best chance to actually lose the virus, at least actively in these patients. And we know that from data that's been published that stopping treatment, particularly in e antigen negative patients, may lead to higher rates of surface antigen loss. And this is thought to be due to some kind of immune surveillance compared to patients staying on treatment. But as I have and many providers have been fearful of stopping treatment because we've all seen reactivation hepatitis in patients be pretty severe occasionally. But more commonly, it's not a severe reactivation. It may be a little bit of a flare that calms down with time. But generally, our guidelines have erred on the side of staying on treatment as there's no definitive cure right now. So there is lots of data I mentioned showing surface antigen loss is higher in patients who have stopped treatment, particularly who've been on entecavir-based therapy more so than tenofovir-based therapy. Surface antigen is more likely to be lost in Caucasian patients than Asian patients. But even still, you only have about a 15 to 20% likelihood that in 5 years after stopping treatment, you'll lose surface antigen. Now, that sounds like a low number, but again, that's saving drug in 1 out of 5 patients. So sort of economically, it makes sense, but from an individual patient perspective, it's unlikely to occur. So at the moment, there's no clear guidance on who may best be a candidate for attempted treatment discontinuation with the intent to provoke surface antigen loss from any of the major societies, but there is some published data from Taiwan as well as from Japan that I'll show you in a second that may be worth looking at. Now, if you do decide to stop treatment, frequent monitoring is definitely important. And how frequently, generally about every month for the first few months and every 3 months for at least the next year. I'm just going to show you one table here from an interesting paper out of Taiwan. And the reason Taiwan became important here was that in Taiwan, they only covered treatment for 3 years for patients for hepatitis B. And after 3 years, the patients had to decide if they were going to pay out of pocket for treatment or if they were going to stop the treatment. So it allowed for sort of real life analysis of what happens to patients who stop treatment. So if you look at some of the top data here in patients who did not stop therapy and either with entecavir or tenofovir-based therapy, over a range of 5 to 10 years, you're seeing somewhere between 1.6 and 5% of patients lose surface antigen. So again, not very common with multiple years of therapy. But in the Taiwanese data, in patients who stopped treatment after 3 years, about 36% of these patients were able to lose surface antigen over a period of 6 years. And there were about 19% who had some kind of flare, but didn't need to go back on treatment, and about only a small percentage of patients that needed to go back on treatment with clinically significant flaring. So again, this is still not a high number, but it raises the question of, is that something we should be thinking about more in patients? So there are a couple scoring systems we can use to predict surface antigen loss. The Japanese Society of Hepatology has a score that looks at the quantification of surface antigen in the blood, as well as the quantification of hepatitis B core antigen at the time that you're thinking about stopping treatment. And if their levels are low on both of these, then the low levels predict more success in losing surface antigen over the next 5 years. In Taiwan, they developed something called Scale B, which looks at the surface antigen quantitative level, the core antigen level, their age, the ALT, and whether or not they are on tenofovir, as I mentioned, is less likely to lose the surface antigen if they were on tenofovir in their experience there. And if the total score here is less than 260, there was about a quarter of patients would lose surface antigen within 3 years of stopping therapy. And those would be candidates that they may say, hey, save your money and don't buy the drug here. Now, these are problematic in the US to use them because we don't typically monitor surface antigen quantifications very often. It is a test that is available through LabCorp and Quest in particular, and core antigen testing is not available in the US. So that hasn't caught on here yet in terms of scoring systems, but they're interesting things to think about for the future as more testing becomes available. So going back to our case, this is again a 45-year-old man who wants to stop treatment because it's expensive and he wants to save money. So, in this patient, we could consider checking the surface antigen quantification. And if it's low, it may be reasonable to stop and monitor his labs every 1 to 3 months and see if he flares. And just kind of reinforce that he'll need lifelong monitoring and he'll also need lifelong cancer screening as he still has hepatitis B. He just may not necessarily need medication forever. So I think, again, this case is a little bit of an uncommon example in my practice, but it is something that does come up from time to time and is always a question that patients are asking, can I get off medication or not? So in summary, here's a few take-home points. Number one, you're going to treat patients with immune active hepatitis B. Again, high viral load, high ALT treatment. All cirrhotics should be treated, and patients who are at higher risk of liver cancer or chronic liver disease should also be treated. Tenofovir and entecavir-based therapies are first-line therapies. These medications are effective and they have low resistance likelihood of occurring. Stopping treatment is uncommon, but can be done in some patients, particularly if they lose surface antigen. If treatment cessation is mandated, usually by patient preference, think about using quantification of surface antigen levels to help guide your risk analysis for that patient. And again, don't forget to continue lifelong monitoring and liver cancer screening as it is not yet a curable disease. Thank you all for your time, and I'm happy to take any questions you have.
Great. Thank you so much. Really awesome presentation, really informative. I know we had a couple of questions in the chat box, which I think that you answered the first, which was how common is S antigen loss? And I think you mentioned around 5% depending. Is that accurate?
Yeah, on treatment, it's somewhere between 2 and 5% in 10 years. So, it's not that common, but I'll usually tell patients that if you're on treatment for 20 years, I got about a 20% chance they're going to be able to stop therapy. And that's not always heartwarming to most of those patients, but it is a potential for some.
And then another question we had, is there a benefit of TDF over TAF other than insurance or cost? Looks like, when do you prophylax for Hep B core positive patients? So this, I didn't talk about this because I think this had been covered in a different discussion earlier in the ECHO series, but generally speaking, in patients who are going to be on long-term immunosuppression who have exposure to hepatitis B in the past, you want to think about prophylaxing those patients. And there's guidance from American College of Gastro, which is a pretty aggressive guidance that sort of breaks up patients into low, moderate, and high-risk groups. High-risk groups are patients that are going on rituximab-based therapy or sort of big gun chemotherapy. Moderate risk groups are patients that are on sort of moderate dose of prednisone or perhaps biologic agent. Low risk would be maybe somebody going azathioprine or mycophenolate or a low dose prednisone for a while. And, again, depending on the patient, I tend to err on the side of offering prophylaxis to most of those people, or at least offering close monitoring, and mainly because I don't want them to have to worry about flaring hepatitis in the middle of whatever they're getting done. One of the groups I often forget about in my own practice are patients with alcoholic hepatitis. We're seeing more and more of that during the pandemic, and it's important to check the core status in these patients too. If they're going to be on prednisone for at least a month, they're at risk of reactivation. So those are another group of patients to think about. Thank you. Sorry, I think my connection may have cut out for a second there. Can you hear me okay?
Yep.
Okay, cool. One of the questions that we got was also, is there a benefit of TDF over TAF other than insurance or cost?
Yeah, I don't think so, no.
Okay. And then you mentioned insurance challenges potentially kind of helping to dictate what treatment.
Can you talk a little bit about some of the things that you might encounter and maybe some tips for others on how to address and overcome some of those challenges that you might experience with treatment?
Well, I guess one of the tips would be that if you really feel strongly about one particular drug, do what you can in advance of ordering that medication to kind of get your chances high. So if you have a patient, for instance, that you really wanted to put on TAF, maybe do a DEXA scan before you order the drug. And if you show osteopenia, you usually can get it approved. If you don't do that, you're going to get denied, and then you're going to have to do it. So sort of setting that patient up for success ahead of time would be helpful. In patients who have chronic kidney disease, you can usually get TAF over TDF approved. I think where it gets harder is arguing for entecavir ordering TAF over entecavir, because most of the data showing superiority or efficacy of TAF is compared to TDF, not compared to entecavir. So it's a little harder in a patient who might have HIV co-infection. It's easier. You can usually get what you want approved in that patient. And somebody who is otherwise just like a regular run-of-the-mill hepatitis B patient that we see, sometimes we are stuck with using whatever we can get. But I think arguing ahead of time with that patient, or at least prepping them that might be a scenario they encounter, is worthwhile to spend a couple minutes on that.
Thank you. Myra, I see you had a couple of questions in the chat. Did you want to ask them?
Sure, thank you. You raise a really good point, Dr. Finkel. Thank you. I always love your presentations and the information you provide. So useful. But if you have, you raise a good point about prednisone, and I feel like it's used very freely, often too freely, by primary care providers who may not know the core status of the patients. That being the case, would you advise primary care providers to screen more carefully for Hep B core presence, with consideration to how much prednisone they're putting them on? Or, I think it's a little more obvious if patients are getting treated for things like rheumatoid arthritis or things along those natures. That specialist is going to probably check for any prior exposure to Hep B just based on the medications. But I don't think that's the case with primary care providers.
No, I think you raise a good point there too. I can't say that I've treated asthma in a while, but if it's something where you're just giving them a 5-day course of prednisone, it's probably low risk. You don't have to do it. But if they're on that once a month, that's certainly somebody that could flare. I've even seen somebody flare after epidural steroid injections for lumbar radiculopathy or something like that. So it's possible if it's repeated. Hopefully that will be addressed with the potential upcoming change to our Hep B screening guidance, where it's going to be recommended that all adults get triple screened. So we'll know their core status. But until that's implemented, for sure, if you have a patient that has a real severe steroid or real severe asthma, it's worth considering screening them for Hep B and exposure as well.
Right. Case in point, I had someone who was on 20 milligrams of prednisone for 10 days because she had an allergic response to some medication that a colleague had put her on. Long story short, she was really having an adverse reaction to an ACE inhibitor, but the patient was persistent in asking me for more prednisone. And, I was absolutely not. You just don't understand how this is not an innocuous drug, and you really should not just give it without knowing multiple factors about the baseline history of the patient.
Sure,
So
thank you. Looked like there was a question in the chat from Dr. Chuko also. So the question was whether or not there's a risk of getting hepatitis B virus from a blood donor who was core positive and surface antibody positive. I mean, that really should be zero in a perfect system where you're doing NAT testing typically on the blood. So there should be nucleic acid testing done to prove there's no virus in the blood. And just because there's antibodies present, that should be okay. We see that pretty commonly with like IVIG infusions, which often have presence of core antibodies. So I would say that the risk should be zero. I guess it's technically 1 in a million, but it's probably zero.
And then another question that came through, do you treat all patients prophylactically for HCV treatment?
I do. Now, this would be patients who are surface antigen positive. I do. If they're core antibody positive, I don't. Basically, those patients, we just watch their liver tests. If the liver tests go up as the Hep C is going down, then they get treated for Hep B too. But I've seen like one flare of hepatitis B in a patient treated for Hep C, and I've treated thousands of people for Hep C. It's pretty uncommon. But for co-infected patients, yeah, I treat them for B.
Thank you. Really great discussion. Thanks everybody for the really great questions as well. We can move on to our case. I do want to provide one